What's up, Ninja Nerds? In this video, we're going to be talking about acute kidney injury. If you guys want to follow along with some really helpful, comprehensive notes, illustrations, go down to the link below to take you to our website. Get that stuff. It's really going to help you to understand this topic. Also, if you guys like this video, you benefit from it, it makes sense, please hit that like button, comment down in the comment section, and most importantly, subscribe. All right, let's talk about AKI. All right, Ninja Nerds, so let's talk about AKI. So acute kidney injury is whenever the kidneys obviously have been injured through particular causes that we'll pretty much spend a decent amount of time talking about. But whenever the kidneys are injured, the kidneys are responsible for being able to excrete particular metabolic waste products, urea, creatinine. But whenever the kidneys are injured, their ability to excrete creatinine, their ability to excrete urea maybe decreases a little bit. And so as a result, the patient may develop an increase in their BUN or an increase in their creatinine as a result of some type of particular injury. And we'll talk about pre-renal AKI, intra-renal AKI, and post-renal AKI. The other thing that may actually happen as a result of the kidney being injured is not just an increase in these metabolic waste products because of the decreased ability of the kidney to excrete these substances or filter them, but also the ability to make urine maybe goes down. And so what happens is, as a result, they develop a decrease in their urine output. Now, the particular causes are easily remembered as pre-renal, intra-renal, and post-renal AKI. Now, pre-renal AKI is that the patient develops an increase in their creatinine, an increase in the BUN, or a decrease in their urine output as a result of some type of issue where the blood flow to the kidney, so we think about pre-renal, the blood supply to the kidney is actually reduced in some way, shape, or form. There is a reduced blood flow. Now, what could be the causes for something having reduced blood flow, reduced perfusion to the actual kidney? The easiest one to remember is that there is a decrease in the actual blood volume. Okay, so there's a decrease in the blood volume. If you have a decrease in the blood volume, there's potentially a decrease in the actual blood pressure, decreased perfusion to the kidney, and therefore decreased ability to excrete metabolic waste products and make urine. What are particular easy things to remember as causes of a decreased blood volume? One of the easiest things to remember is actually whenever there's not a problem where your total body volume levels are lower, but it's actually where you have maybe a normal total body volume, but the amount of volume in the blood vessel, the effective arterial blood volume, is lower. What are conditions where the effective arterial blood volume is lower, but you actually have a total normal body volume? Conditions that are usually like hypervolemic related. Or you're third spacing a lot of fluids. What are some examples of these? One of the big ones is when someone has CHF. You know, when someone has really significant heart failure, they have CHF, the pumping function of the heart is decreased. So maybe the left ventricle is all jacked up. It's not pumping well. It's not having a good cardiac output. What happens when you have a reduction in the cardiac output because maybe a person has CHF and their ejection fraction is really low? So in other words, the volume of blood that they're pumping out, the percentage of blood that they're pumping out of the ventricles is much lower. What may result in a low cardiac output? If you have a low cardiac output, that leads to a low mean arterial pressure, which is your perfusion pressure. If you have reduced perfusion to the kidneys, what happens? Reduced blood flow to the kidneys, and as a result, this can lead to acute kidney injury via the increase in BUN, increase in creatinine, and decrease in urine output. So CHF would be an example of where maybe they have a total body volume that's actually normal, but the amount of volume that's actually being circulated through the blood to the kidney is lower. And this is actually one example. We actually give a particular name to this whenever the heart is responsible for this AKI. It's actually called cardiorenal syndrome. I want you guys to remember that, okay? So cardiorenal syndrome is when a person has some type of cardiac cause, usually CHF, that leads to this AKI. Okay, beautiful. What's another particular cause where you actually have a decreased total effective arterial blood volume? Another example of this would be someone who has what's called liver failure. So if someone has very severe, let's say, liver failure, so significant liver failure, you know what the liver is actually responsible for making? Proteins. You know there's a protein that the liver makes. It's called albumin. And albumin is a beautiful protein. Imagine this protein gets excreted into the blood, right? And here's this protein. What it does is, imagine albumin is like a little water sucker, right? It's pulling and keeping water inside of the blood vessel, right? So imagine this is like a little kind of like, it's osmotic gradient really. It keeps and pulls water into the vasculature. So what happens is if someone has liver failure, their ability to make proteins decreases. So what happens to the albumin production? It drops. What happens to the ability to pull water into the blood vessel or keep it in the blood vessel? It decreases. And so as a result, less water is actually being held with inside of the vasculature, and instead it actually may, what do we call this when some of the fluid actually doesn't stay in the vessel, but it kind of sits in the interstitial spaces? It's called third spacing. So they may actually start having less fluid, less effective arterial blood volume. Let's write that down. So what's the result out of this? This is resulting in a decreased effective arterial blood volume. And so what happens is, as a result, you have less actual volume of blood within the vessel, and that lowers your mean arterial pressure. And that lowers the perfusion to the kidney, which can lead to a AKI. Okay, so we actually, whenever somebody has severe liver failure, this could actually be a cause due to hypoalbuminuria. There's another condition where you actually do the same thing, except you don't actually, it's not an issue of production, it's because the kidneys are injured. And they start actually having excretion of lots of albumin. So lots of albumin ends up in the urine. Okay? So you have albuminuria or proteinuria, and a lot of it. And what happens is, because you're just getting rid of tons of albumin, what happens to the albumin levels in the blood? It's the same kind of effect. Less albumin is in the blood because more of it's in your urine. You have less ability to hold on to the fluid. Your effective arterial blood volume drops, and that can lower your MAP, and it can lower the perfusion to the kidney, leading to an AKI. What is this called? This right here is called nephrotic syndrome. So nephrotic syndrome is usually where they have proteinuria, lipiduria, they have hematuria, they also have a lot of edema, hypertension, things of that nature as well. All right, so again, just wanted to make sure you guys understand that. So far we have CHF leading to a low perfusion to the kidney, right? Cardiorenal syndrome, liver failure, nephrotic syndrome. These are leading to low albumin within the blood, hypoalbuminemia, right? Whether it be actually decreased production or you're actually getting rid of a lot of albumin into the urine. There's another condition which can actually lower your effective arterial blood volume, and it's because you're, again, third spacing a lot of fluids. You know, in a patient who has what's called pancreatitis, so acute pancreatitis, there's so much inflammation that whenever there's all of those cytokines and proteases that are being released, it causes these blood vessels to become super leaky. And so your total volume actually could be normal, but your actual vessels are so leaky that they actually start having some of the fluid that is in the plasma leaking out of the blood vessel. And so a lot of the fluid starts to sit outside of the vasculature. What is this called? Third spacing. So it actually does what? As a result, having severe pancreatitis. You have third spacing of fluid, which leads to a low effective arterial blood volume, less perfusion to the kidney, leading to a kidney injury. So this is another condition can actually do this. You know, when you have a really, really bad bacterial infection within the blood, and it's actually causing significant vasodilation, increased capillary permeability, and it's usually due to a really nasty infectious source that's causing hypotension, it's causing fever. What is this? Sepsis, right? So if someone is actually having severe sepsis, particularly with shock, so septic shock, they may start having significant vasodilation, increased capillary permeability, third spacing a lot of their fluid, lowering their effective arterial blood volume, lowering their mean arterial pressure, lowering their perfusion to the kidneys, again, leading to an acute kidney injury. We're so good, we can make sense of this stuff in engineers. Okay, so what I want you to remember is low blood volume leading to an AKI. These are some of the things that I want you guys to think about. And two of these is usually due to your third spacing fluids, whether it be low albumin or a lot of capillary permeability. Or the other one is you're just not perfusing the kidneys because not a lot of it is actually leaving the heart. And because of the heart having severe failure, instead, you could third space, but where would it third space if you had left ventricular failure? Into the lungs, pleural effusions, pulmonary edema. If you had right side heart failure, where would it third space? Into the abdomen, into the legs. So it's the same kind of concept. Okay, beautiful. Let's talk about another situation. Now this problem is actually where you have a low total body volume, where you're losing tons of volume from the body. And it's not actually a low effective arterial blood volume, it's just low total volume. What are conditions where you could actually, it's like an exorcist, and you're just, whoa, vomiting, severe vomiting, right? And severe vomiting, if you're vomiting a lot, you're getting rid of a lot of fluid. That's fluid that could be potentially absorbed across the GI tract. And so that's a decreased fluid intake in that sense. Or if you're peeing out your butthole and you have diarrhea, that's again volume that you're not having a lot of time of motility, there's little absorption that's actually occurring, and you're losing a lot of total volume from the body. So severe vomiting, severe diarrhea, what's another thing that could actually be due to? What if you're not just taking as much water or fluids as you should be in? And so there's actually just a decreased intake. So sometimes if you have a severe dehydration due to decreased intake, that may also be a potential cause. So again, vomiting, diarrhea is you're losing it from the GI tract or you're not taking in as much. Another thing, whenever somebody's like severely sweating, like sweating hard, and you're having a lot of evaporative cooling effect here. So excessive sweating, what would be conditions where you could be excessively sweating? Maybe hyperthermia, maybe fevers. In situations where there's really, really significant sweating, you could be losing fluid, a lot of losses from the actual skin. Another one where you actually have lots of evaporative kind of losses of fluids because of the loss of the skin barrier being intact. Severe burns, usually like 3rd degree, okay? These are things to think about. You know what another one is? Sometimes we do this to patients, unfortunately. They're a little bit fluid overloaded, or maybe we are trying to give them a little bit of Lasix because they're a little bit swollen, or we're giving them furosemide. And when we give them the furosemide, or we give them some type of diuretic, maybe we just give a little bit too much of a diuretic and we don't keep an eye on it. And because of that, they start just peeing loads. And because they're peeing loads and loads of fluid, guess what this fluid is? Whenever you use something like diuretics, particularly furosemide, loop diuretics, it's more of a dilute urine. But either way, you're losing a lot of fluid. That's a total volume loss there. So excessive diuretic use, or someone actually having a lot of diuretics, could be one of the causes for their dehydration or their total volume loss. Another one, believe it or not, is if you actually have blood loss. Blood actually is a good chunk of when we lose blood, we're losing red blood cells, white blood cells. You're also going to be losing some platelets. Those are your formed elements, right? But what's one of the biggest components of blood? When we talk about blood, we have red blood cells, which is the erythrocyte layer. Then you have the buffy coat, which is your white blood cells and platelets. But what's like 55% of your blood? Plasma. Plasma is a part of our blood volume. So whenever you have someone who's actually bleeding, like maybe they have some type of bleed from someone. In this case, let's just say that they have some type of urogenital bleed of some kind, right? And if there's blood loss, that blood loss, you're actually losing plasma. And that could be another potential cause of them having a total volume loss. All right, so we have a total effective arterial blood volume is low, or third spacing of fluid. These are above causes. And then these ones are you actually have a total volume loss from the body. But either way, the whole concept is the same. And that if you actually think about it the same way, if a person is having all of these particular conditions, whether they're losing fluid from the GI tract, from the skin, excessive diuretic use, or blood loss, you're lowering what inside of the blood? The total blood volume inside of the blood is reduced. If you lower the blood volume, that will actually lower your blood pressure, particularly the mean arterial pressure, less perfusion to the kidneys, and as a result, inducing AKI. Okay, beautiful. That is by far going to be the most common cause that I want you guys to remember. The other two causes that I want you guys to think about as potential causes of a pre-renal AKI. Again, something before the kidney. Usually it's the blood vessels that are being affected, that are perfusing the kidneys. One is there's actually some type of large vessel blockage of some kind. So the large vessels that actually supply the kidneys. What are the vessels that supply the kidneys? The renal arteries, right? So let's say that you have some type of blockage of the renal artery. What would be a condition which would put you at a susceptibility where you can throw clots and it can go anywhere. It can maybe go to the brain. It could go to the kidneys. It could go to the spleen. It could go to your GI tract. It could go to a limb. What is that condition? AFib. So you know in a patient who maybe has AFib, atrial fibrillation, and they throw off a clot, they embolize. And that clot, which was in the heart, goes and embolizes inside of one of the renal vessels. This can lead to a renal embolus. So this is a potential thing to think about. If you have a really significant renal blockage, you're reducing blood flow to the kidney. Or not just a renal embolus, but you know there's patients who get a lot of fatty plaques with inside of these. Yeah, let's actually kind of write down here. Let's say you have a person here who has like a nice like fatty plaque because they don't take care of themselves. They got a lot of renal artery stenosis. And a patient who has what's called renal artery stenosis, you know, and actually particularly to be important here, it's usually bilateral. So whenever they have both vessels that are really, really hurting, because you still get a little bit of flow here. Right? In a renal embolus, you might have a complete blockage of flow. In a renal artery stenosis, it's just narrow. So you may still get a little bit of flow to the kidney. But if you have bilateral kidneys, you have a significant reduction in blood flow to both the kidneys, and therefore you'll definitely develop a severe AKI. You know there's another condition. I'm going to just draw another vessel here. But it's imagine here you have another vessel, and it's actually really kind of like thick and narrowed and dilated portions. This also can really, really affect blood flow to the kidney. You know there's a condition where you have kind of this, imagine like a beady kind of appearance of the vessel. It's called renal artery fibromuscular dysplasia. Okay, so it's kind of like a dilated, narrow portion of the renal artery. Believe it or not, renal fibromuscular dysplasia can actually significantly reduce blood flow to the kidneys as well. So big things to think about is a large vessel blockage, renal artery embolus, renal artery stenosis, or renal fibromuscular dysplasia. All right, so the last thing that I want you guys to think about for renal, particularly pre-renal AKI, is we've talked about the total volume loss, we talked about a large vessel blockage, but what else? What if we actually get into like some of the smaller vessels of the kidney? You know, the renal artery will give off branches. Eventually it'll, you'll have like your arcuate, you have your lobar arteries, your arcuate arteries, you have the cortical arteries, and then you have the afferent arterial, right? Well, the afferent arterial eventually feeds into this tuft of capillaries called the glomerulus. And then from the glomerulus, it exits out via the efferent arterial, right? So we have what's called the afferent arterial. Blood will come in, should usually get filtered at this actual capillary tuft here called the glomerulus, and then exit out via the efferent arterial. What if I actually caused significant and widespread multiple glomeruli? Because this is where the filtration is happening, right? What if multiple afferent arterioles, I really squeeze them super hard? I squeeze the living crap out of these things. So I clamp down on the afferent arterial. And if I clamp down on the afferent arterial, what would happen to the blood flow that's actually going through here? It would decrease. Well, in the same way, let's say that I come over here and I talk about the efferent arterial. What would happen if I actually dilated the efferent arterial? Then a lot of blood would be able to easily leave out of the vessel. So a lot of blood would leave out of the vessel. And if a lot of blood leaved out of the vessel, that's less time here in the glomerulus. And actually, if you dilate it, it lowers the pressure, so it's easier for blood to leave out. So what can happen is we can have certain things that can cause renal artery, the afferent arterial, to undergo constriction, and then the efferent arterial to undergo dilation. And if you constrict it, there's less blood that's going into the actual glomerulus, so less filtration. And if you dilate the efferent arterial, more blood's able to exit easily, and it lowers the pressure inside of the glomerulus, which lowers filtration. So the effect of both of these things can lead to a low glomerular filtration rate. That's going to lead to less excretion of nitrogenous waste products and low urine outputs. So what kind of things can cause this? I'm glad you asked. You know, there's a condition called hepatorenal syndrome. It's kind of similar to someone having severe liver failure. So let's say that someone has really, really bad liver failure, right? Whenever you have really bad liver failure, there's a condition that can happen as a result of this called portal hypertension. It's basically, there's veins that actually come to the liver from your GI tract. They're called the hepatic portal circulation, right? And you're supposed to be able to take blood via the hepatic portal circulation, take it to the liver, and then what happens is there's another big vessel here called the IVC. The liver will actually clean all the blood that's coming via the hepatic portal system, and then once it cleans it, it puts it into the inferior vena cava to go to the right heart and then distribute to the lungs, get oxygenated, and so on and so forth. In a patient who has hepatic portal hypertension, these vessels are so fibrotic and there's so much inflammation in the liver that it reduces the portal blood flow. And so the liver says, oh man, I'm not getting enough blood to be able to deliver to the IVC. So what I'm going to do is I'm going to start releasing some chemicals. I'm going to start releasing some vasodilators. Okay, some vasodilators. And the hope is that these vasodilators will counteract this actual high pressure. And so if I counteract the high pressure, I'll get more blood flow, hopefully going through the liver and then getting filtered into the IVC. But you know what actually happens as an unfortunate result? You do cause some splanchnic vessel vasodilation, but these vasodilators actually get into your systemic circulation. And when they get into the systemic circulation, guess what they do to multiple blood vessels in your systemic circulation? It causes the systemic vessels to undergo a vasodilatory effect. What happens when you vasodilate multiple systemic vessels? Well, it's going to actually lower your blood pressure. When your blood pressure lowers, and it actually kind of lowers your effective arterial blood volume, when you lower your systemic blood pressure, what does your body try to do in response? It says, hey, blood pressure's low. I need to try to increase the blood pressure so I can perfuse vital organs. And I need to constrict the vessels to organs that are viewed as non-vital. Guess what? The kidney, unfortunately, is viewed as non-vital in low blood pressure situations. So when this happens, this low blood pressure will actually cause intense renal artery and afferent arterial vasoconstriction. And so it'll stimulate this vasoconstrictive mechanism, which reduces the significant amount of blood flow to the glomerulus, reducing your glomerular filtration rate. And another thing that also happens is whenever you have low blood pressure, it actually activates what's called the renin, angiotensin, aldosterone, ADH system. And you know what they do? What are they supposed to do? They're supposed to cause a little bit of renal artery vasoconstriction. That worsens that. And then also, ADH and aldosterone, they're supposed to reabsorb sodium and reabsorb water. If you reabsorb these, that means less of it's in the urine. That lowers your urine output even more because you're reabsorbing whatever little GFR you had, whatever little urine that you were going to make. Now the ADH and aldosterone that you just had produced, you're going to reabsorb that little sodium and water. And so this is going to lower your urine output even more. Okay, so unfortunately, this is what happens as a result to try to be able to preserve your blood pressure, but it can unfortunately affect the kidneys a little bit. And this condition, where the liver directly affects the kidney or indirectly affects the kidney through these mechanisms, is called hepatorenal syndrome. And again, this can also coincide with what we talked about above, having low albumin. So you can kind of get a double whammy with this kind of effect. Now, what other things can actually cause constriction of the afferent arteriole? There's drugs that we love to pop a lot whenever we're in a lot of pain. NSAIDs. So NSAIDs, believe it or not, have a pretty significant afferent arteriolar effect and vasoconstriction. So that can actually kind of reduce your GFR. And another one is what's called tacrolimus. It's actually what we use whenever someone gets like a kidney transplant and you're supposed to help prevent rejection, but it's a calcineurin inhibitor. So these are the kind of drugs that would particularly affect the constriction effect. Other things, believe it or not, is, when you have very, very high calcium levels, super high calcium levels, and whatever the condition may be that actually causes this hypercalcemia, maybe it's a malignancy, maybe it's a parathyroid hormone that's being too high. Either way, high calcium loves to act on those afferent arterioles. And high calcium, a lot of calcium gets into those actual smooth muscle cells, induces the vasoconstriction, also reactivates the renin, angiotensin, aldosterone system, and that can cause this intense renal artery vasoconstriction. But there's other things that you want to think about. You know, there's some nasty little drugs sometimes. They're not nasty, but they can be they can have some nasty effect on some people. Is you use it for blood pressure, and sometimes they can cause a little bit of a nasty effect. They're good in patients with high blood pressure who also have diabetes, who have heart failure, and they're called ACE inhibitors or angiotensin receptor blockers. These ones particularly work by inhibiting angiotensin 2. Angiotensin 2, you know what it does in the efferent arteriole? It causes vasoconstriction. Because if you constrict the efferent arteriole, what would that do? It would actually lower the amount of blood that's leaving the glomerulus. It would also increase the pressure within the glomerulus. What would that do if you increase pressure and you have less blood that's leaving the glomerulus? It would cause higher glomerular filtration rate. You'd be able to make more urine, right? If I give a drug that's actually going to cause vasodilation of the efferent arteriole, it's opposing angiotensin 2, and therefore it's going to cause dilation, reducing the GFR. So that is kind of sometimes the unfortunate effect of ACE inhibitors and ARBs. Okay, we have hit up the pre-renal AKI causes. Let's now talk about the intra-renal AKI causes. All right, so the next one that we got to talk about is intra-renal AKI, right? So now it's pretty easy to understand now. When we talked about pre-renal, it's a problem with blood flow, right? It's an issue with blood flow. There's a reduced blood flow to the kidney. But in intra-renal AKI, the person is having, again, low urine outputs or having high BUN, high creatinine, but it's not due to an issue with the blood flow. It's an issue with the kidney itself. So the kidney tubules, the small little vessels like the glomeruli are affected in some way, shape, or form. But yeah, that's kind of the big thing, is it's actually a kidney injury, particularly something wrong with the renal parenchyma, whether it be the small little blood vessels or whether it be the actual kidney tubules. What are the particular things that I want you guys to remember? By far, the most common cause of intrarenal AKI is what's called acute tubular necrosis, often referred to as ATN, okay, ATN. Acute tubular necrosis has a couple different causes. One is it actually could be due to significant reduction in blood flow. So you know whenever somebody has a pre-renal AKI, right? They have very little blood flow. So one of the other ones to think about with intrarenal AKI is someone has very, very low blood flow for long periods of time. So low blood volume for a long period of time. It's not corrected. Right? Especially someone with sepsis. Hey, look at that, perfect. Someone who has sepsis, severe sepsis that goes on for long periods of time, it really, really lowers your effective arterial blood volume. And if it's not effectively treated, that reduces significant amount of blood flow to the kidneys. And guess what? The little kidney tubules, those little cells, they depend upon oxygen as well to be able to work. And if you're not giving oxygen to these poor little guys, what's going to happen? They're going to undergo ischemia. What happens if ischemia is not actually reversed? It undergoes necrosis and the tissue cells die, and the kidney cells themselves lose the ability to perform their functions. And we'll talk about what that is. So that's one big thing to think about, is someone having a very low blood volume for a long period of time. One of the best examples is actually septic shock. Worked out perfectly. All right. The second thing is medications, okay? So certain types of drugs. And there's a lot of them. I am not going to go through every single drug. I don't want you to focus on that. I want you to know some of the big ones to think about. And the particular ones to think about is actually antibiotics. So two of the antibiotics that I actually do want you to remember here is what's called aminoglycosides and another one called vancomycin. These are pretty common drugs that we prescribe a lot, especially vancomycin, and that's definitely one that can actually cause an acute kidney injury. It actually directly damages these beautiful, cute little proximal and convoluted tubular cells and different types of tubular cells within inside of the actual nephron. It damages those little guys, and so their inability to reabsorb and secrete and perform those normal functions. Another one is antivirals, actually, believe it or not. Antivirals. You know, there's acyclovir that we actually can prescribe in certain types of infections. Acyclovir is actually kind of a nasty one as well. So these are some. There's also other drugs like methotrexate and many different types of drugs, but these are kind of the big ones that I want you guys to remember. One more we also kind of give a lot is contrast dye. So sometimes if someone is actually getting contrast, radioiodine contrast, stuff like that, contrast dyes actually may have a little bit of an effect on the kidney tubules as well and cause direct injury. So again, remember these drugs are nephrotoxins, so they actually cause direct injury to these actual kidney tubular cells. Okay, so we have reduced blood volume, we have drugs that directly damage the kidney tubules. You know what else can actually directly damage these kidney tubules? You know that whenever somebody has a lot of damage to red blood cells, what is that called when you like pop these little suckers open and you release out a lot of hemoglobin that gets released out freely circulating? And that's a nasty little son of a gun sometimes. Sometimes if it actually gets down here into the kidney tubules, it actually can, again, it can get taken up into the hemoglobin and the iron can actually get taken up into these actual acute tubular cells and cause direct nephrotoxic injury. You know, not just hemolysis, but you know there's a protein similar to hemoglobin, but it's actually kind of in our skeletal muscle cells. And whenever our skeletal muscle cells get all jacked up, in a condition like rhabdo, you know, someone has rhabdomyolysis, they have their injury to the actual skeletal muscle, whether it be a crush injury, whether it be trauma, whether it be overexertion, seizures, all that good stuff, it starts spilling out tons of myoglobin. And that myoglobin starts getting into the bloodstream, and it actually starts getting taken into the kidney tubules, and it gets taken up into these kidney tubular cells and causes direct nephrotoxic injury. Boom, shabam. You know, another condition, you know, whenever someone has a nasty cancer, so let's say that you have a bunch of cancer cells. You know, this is pretty common sometimes in like leukemia, lymphoma, stuff like that. But you have tons of cancer cells and you're actually getting chemo. And what happens is the chemo is designed to be able to kill these sons of guns. But what happens is when you kill a bunch of cancer cells, they spill out some of the actual metabolic waste products. And you know what one of those nasty ones is? Uric acid. And whenever you have lots of uric acid that gets spilled out, believe it or not, it actually does cause direct nephrotoxic injury to these poor little tubular cells and their ability to be able to reabsorb urea and excrete creatinine and reabsorb sodium and water. All that stuff's all jacked up. You know, there's another condition. You know, another condition is called multiple myeloma. You know, multiple myeloma is whenever you have these plasma cells, we'll put multiple myeloma. And what happens is these plasma cells, they produce tons of kind of like proteins, right? But one of the proteins that they actually produce is called a Bence-Jones proteins. And these Bence-Jones proteins actually will get taken through the blood, taken to these actual tubular cells within the kidney and cause direct injury to the tubular cells. These are the Bence-Jones proteins. So again, these are the things that I really want you to remember. There's one other thing, I don't think it's super high because you don't see it that often, hopefully, but people who actually, unfortunately, this can come up in a clinical vignette, is when a child gets a hold of like antifreeze, ethylene glycol. And it can cause visual changes as well, but this also has the ability to cause direct nephrotoxic injury, okay? So again, if you damage these kidney tubules, their ability to be able to reabsorb, secrete substances, and the ability to actually help to play a role within glomerular filtration becomes very, very affected. And we'll explain that pathophysiology a little bit later. All right, so we got the causes for acute tubular necrosis, which is the most common type for intrarenal AKI. What's another one that I want you guys to think about? The next one, not so common, but again, something to think about, is called acute interstitial nephritis. This is also referred to as AIN. Now, acute interstitial nephritis is actually whenever you have damage or injury to the kidney tubules, and it's a lot of inflammation of the kidney tubules and the actual interstitium around the kidney tubules. Okay, what kind of condition would cause a lot of inflammation? So let's actually do this in a different color. Let's do like pink or something. So what condition would cause a lot of inflammation of the interstitium, so the spaces between the blood vessels and the actual kidney cells, the tubular cells, or a lot of inflammation directly of these kidney tubular cells? Imagine them really sad and crying. What would be some conditions? Well, first thing is drugs. It's always drugs, right? So what are some? One of the big ones is actually going to be your beta-lactam antibiotics, so your penicillin antibiotics. These are big. The other one is PPIs, believe it or not, so proton pump inhibitors. These are also some ones that actually can cause a little bit of injury as well. There is other ones. I don't want us to get hung up too much on these, but yeah, PPIs, beta-lactams, those are some of the ones that I want you to think about. You know, there's other conditions. They're like infiltrative diseases. They're inflammatory kind of conditions where you can get, you know, the condition called sarcoidosis, where you have a lot of these like inflammatory granulomas that get deposited into tissues. Guess what? If it gets deposited into the area around the interstitial spaces or near the actual kidney tubular cells, this can be enough to cause interstitial nephritis. Or maybe another condition called amyloidosis. Amyloidosis, where there's actual proteins that get kind of deposited into this area. You know, there's another condition when actually patients have a lot of autoimmune disorders. There's a condition, it's called systemic lupus erythematosus, right? And this kind of condition, they have lots of antibodies. And these antibodies that they're actually producing can cause damage to the actual tubular cells and cause inflammation around the interstitium. And even another condition called Sjogren syndrome, right? But you know what else? Infections. Infections, whether it be bacterial, right, Legionella, Streptococcus, viral infections like CMV, hepatitis viruses, different types of fungal infections as well. But infections in general can actually cause injury to these actual tubular cells, inflammation of the tubular cells, and a lot of interstitial inflammation. And again, think about it like this. This interstitium and the tubular cells, if they're inflamed, their ability in being able to reabsorb substances, being able to excrete creatinine, and their ability that affects the actual filtration pressures, all of that stuff is going to be altered, okay? So we have acute tubular necrosis, acute interstitial nephritis. What are the last two components here that I want us to think about here? So there's two other ones that I want you to think about that are actually kind of involving a little bit more of the structure called, we have what's called the glomerular basement membrane. So you have these like capillaries here, okay? This is your glomerular capillaries. Then you have what's called the glomerular basement membrane. And then you have cells. You know, you have some cells here, if I were to actually kind of draw them, they're little foot cells, and they kind of look like little, weird looking things here. These are called podocytes, right? So you have podocytes. You also have other cells called mesangial cells. If I were to draw them, I'll just draw them kind of like this purplish color here. So you have these things called mesangial cells. They're all over the place. But whenever someone has an inflammatory condition, there's kind of an inflammation of all of these areas. Inflammation of the mesangium, inflammation of the glomerular basement membrane, inflammation and damage of the podocytes, right? There's a condition where you have like these antibodies and antigen deposition into these areas. There's a condition where you actually kind of cause inflammation of the glomerulus and the glomerular basement membrane and the mesangium cells and all the kind of those accessory cells. We call this glomerulonephritis. We're just going to represent that as GN. And there's so many different types. We'll have to talk about this in a separate video. So we're not going to spend the time going over all of these. But just remember, this could be a particular cause of AKI because it's going to affect the ability for not just the damage, not just the effect, it's going to affect the glomerular filtration rate, but also it may cause some damage to some of the structures that are involved within the filtration and reabsorption of substances. So again, one of the big things to think about here is that if you damage the actual glomerulus, it can actually affect the glomerular filtration rate, all right? So glomerulonephritis would be another one. The last one, again, these last two that we're talking about, they're not super big. I don't want you guys to spend too much time thinking about them, but it's just something to have in the back of your mind. But in a condition where you have a lot what's called thrombotic microangiopathies, there's a bunch of these. Again, I don't want you to go too ham on them, but something called TTP, thrombotic thrombocytopenic purpura, another condition called hemolytic uremic syndrome, another condition called disseminated intravascular coagulation, and sometimes even in patients who have what's called hypertensive crisis, right? In these situations, you can kind of get a lot of like small little thrombi. So a lot of thrombi that kind of deposit within inside of the afferent arteria, the glomerulus, and it really kind of causes a lot of inflammation and damage to structures within this area. And this can lead to a reduction in glomerular filtration rate. Sometimes this can also be seen in conditions like vasculitis as well. So big thing to think about for intra-renal AKI, what I really want you guys to spend most of your time remembering is particularly the intra-renal AKI, a little bit on the acute interstitial nephritis, but don't go too ham on remembering glomerulonephritis and thrombotic microangiopathies and vasculitides. Okay, now that we got that done, let's talk about the last type of AKI, post-renal AKI. All right, the last type of AKI is a post-renal AKI. So post-renal AKI is obviously, we're getting pretty good at this stuff, right? Pre-renal is reduced blood flow. Intrarenals, there's something wrong with the actual renal parenchyma. Most common is acute tubular necrosis. And post-renals, it's after the kidney. So it's most likely ureter, bladder, prostate area, urethra, something in that part of the urogenital tract is actually being affected, okay? And so we like to think about, something that's actually happening after the kidney. And this issue after the kidney is what's actually leading to an accumulation of urea, an accumulation of creatinine, and a reduction in urine output. What are some conditions that you guys should think about? Well, I like to think about this as something that's usually above the bladder, right? So some kind of issue down from the ureter all the way till we get to the bladder, and then something at the bladder down to at least the level of the urethra. So what are some things that can actually happen? It's actually not that bad, right? So it's something that's involving the ureters. Something involving the ureters has to be wrong here. And you know what's really easy is something like a kidney stone. So sometimes having what's called renal calculus, right, could be a cause. So some type of kidney stone. You know what else could be another particular cause that you got to think about sometimes? Is if there's some type of large kind of like intra-abdominal tumor. Some type of large, maybe it's a colorectal cancer, maybe it's some type of retroperitoneal mass or something of that nature, but there's some large tumor that's actually causing compression. And if it's compressing down on the actual ureter, it again is kind of like in the same way resembling like a kidney stone, okay? In these kinds of situations, usually it actually needs to be a pretty significant effect to actually cause that much of an acute kidney injury. And so usually having like a kidney stone in one ureter or a tumor only compressing in one ureter isn't going to do it too often. And so sometimes this would need to be a bilateral effect. If you had a bilateral renal calculi or you had a significant tumor that was compressing maybe both of the actual ureters, this would definitely produce a very significant type of post-renal AKI. Okay, so that covers those two. Not too much, right? Not too bad. It's actually one of the easiest ones. The other one is actually going to be somewhere at the bladder and urethra level. Okay, so the bladder neck, and the urethra. So what could be some issues that would actually cause this? You know, in males, they have a pretty good sized little donut shaped structure here. And sometimes if it gets really, really like large, which can happen, it's called a condition called benign prostatic hyperplasia. That can actually cause, if it gets really, really big, it may actually cause compression of the urethra, the prostatic urethra, which actually causes kind of an outlet obstruction here. And again, less actual urine coming from the bladder will be able to exit out through the urethra. And then the overall effect is that this could actually cause some type of reduction in urine output. And if it causes the backflow all the way up to the kidney tubules, that kind of pressure buildup, it can cause an acute kidney injury. Other things that can actually cause an outlet obstruction there, not just BPH, but if someone has some type of prostate cancer. So something is similar to that, but like prostate cancer. Or they have some type of urethral injury. You know, sometimes if you have like a significant type of like urethral stricture of some form. And you know, one more. Sometimes in patients who get Foley catheters, they get catheters, and the catheters may be not functioning for some reason. It could actually cause less urine to be coming out via the Foley if the Foley is non-functional. And again, that can cause the pressure to build up back through the ureters, back into the kidney. So we can say a non-functional Foley, which isn't too common, to be honest with you. But again, something to think about. All right, the other thing that you want to be thinking about is maybe it's actually not something that's causing like an obstruction, whether it be BPH, prostate cancer, urethral stricture, or non-functional Foley. Maybe it's actually something wrong with the bladder. It's just not really good at being able to contract. And if the bladder's not contracting really well, it just isn't able to empty contents out. What is the actual condition in which the bladder isn't really good at being able to empty things out? Maybe there's something wrong with the nerves that supply the bladder. Or maybe there's something wrong with the actual muscle, that the muscle just doesn't want to contract. Or maybe the actual urethral sphincters just don't want to react as much. You know a condition called a neurogenic bladder? And again, this could be due to a neural issue. This could be due something to like some type of issue of like multiple sclerosis, Parkinson's disease, strokes. It could be neuropathy, a bunch of different things. But there's some type of issue where the detrusor muscle just isn't contracting as much, or the urethral sphincter is over-contracted, okay? You know another kind of condition is actually not conditions, but medications that kind of replicate this, where medications that are used for patients who are actually having incontinence, they actually wet themselves, right? They have a hard time being able to prevent themselves from actually having episodes of incontinence. And so because of that, we give them medications to be able to prevent the incontinence, But as an end result, it actually causes maybe the bladder to just not contract enough, or maybe it causes the sphincter to tighten up too much. And so instead, they actually don't make urine, and it causes retention. And so medications that are designed to be able to treat incontinence, maybe they start leading to retention. And the best ones to remember here is what's called your anticholinergic medications. Okay, these are things like, we have drugs like what's called oxybutynin, tolterodine, sulfenicin, things of that nature. Okay, that covers all of the aspects of the causes of post-renal AKI and all the causes in general of AKI. Now what we need to do is we need to create a bridge. We need to understand how these causes lead to an acute kidney injury, how that acute kidney injury leads to clinical manifestations, lab values, different complications, so on and so forth. Let's talk about that. All right, so let's talk about the pathophysiology. Now, when we talk about the pathophysiology, we'll go through these and kind of talking about pre-renal, intra-renal, and then we'll quickly talk about post-renal AKI. Okay, and the reason why is we're going to kind of explain a little bit more about the lab stuff, the diagnostics, the things that you really need to know for your exams. So pre-renal AKI, right? When someone has a pre-renal AKI, we already know all the causes. There's a reduction in blood flow, right? And the reduction in blood flow leads to a reduction in the GFR. Now, what I want you to remember is in someone who has what's called a pre-renal AKI, right? There is a reduction in the GFR. And all of these, you're going to have some reduction in GFR. So there's less filtration, right? Less filtration that's occurring here between the glomerulus and the Bowman's capsule. Now, whenever you filter substances, you can filter things like urea, and you can filter things like creatinine, right? Now, in someone who has a pre-renal AKI, it's the primary reduction in blood flow. There's nothing wrong with the actual renal parenchyma. Okay, if it's at the renal parenchyma level, then you're at an intra-renal AKI. But in a pre-renal AKI, these tubular cells are functional. They're working well. There's no issues with these cells. So their ability to reabsorb substances and excrete substances is completely intact. So what happens is you have this excretion of urea and creatinine, but it's a little bit lower in general. Okay, so we can already say that the blood, whenever you have less filtration, right, there's a low GFR, there's less filtration of urea. So you already might have a little bit more urea in the blood, and you already might have a little bit more creatinine in the blood that you prefer because of this low GFR. But the kidney tubular cells are intact. They're working. So you know what that means is your kidney tubular cells, whenever you get urea down here, urea is actually a reabsorbable substance in like the proximal convoluted tubule. And so urea, as long as these kidney tubules are functional, should be able to be reabsorbed back into the blood, right? So that should be intact if these kidney tubules are intact. So you should be able to reabsorb urea if the kidney tubules are intact. Now, if the kidney tubules are also intact, they're supposed to excrete creatinine. And so if these kidney tubules are working, they should be able to take the creatinine and excrete it into the kidney tubules, right? And so what is kind of happening out of this is that you have creatinine that you're excreting, so it should lower the creatinine within the blood. So what do we kind of see out of all of this? The creatinine and the urea generally will increase a little bit because of a low GFR. But because the kidney tubules are intact in a pre-renal AKI, you can reabsorb urea and you should be able to excrete creatinine. So what truly happens to the actual total concentration of urea and the total concentration of creatinine? Effectively, the total concentration of urea actually will go up, okay? But the actual concentration of creatinine, it won't go up too much. It only may actually go up just a teensy bit because just not as much of it is actually being filtered across the actual glomerulus. So we can say that when you compare, if you were to compare a ratio to the blood urea nitrogen to the creatinine, what would it look like? So the BUN over the creatinine, and you look at that ratio, the BUN is super high, right? Because you're reabsorbing urea and you're having less filtration of urea. The creatinine, though, it's just a little bit high because you have less of it being filtered, but you're actually secreting it because you have functional tubular cells. So the BUN to creatinine ratio, we actually say is greater than or equal to 20 to 1. So 20 BUN to 1 of creatinine. Usually the ratio is greater than or equal to that for the BUN creatinine ratio. Then if you also took a look at the urine, if you actually calculated and looked at the urine and said, how much urea is actually in the urine? There's very little urea that's actually in the urine because you should be absorbing the urea because you have intact kidney tubules. Here's another thing that's important. Whenever you have intact kidney tubules and you have urea that's actually being reabsorbed, you know sodium and water? So let's say here we have sodium and water. Whenever there's sodium and water, you know sodium and water actually like to follow urea. So whenever there's urea reabsorption, there's also sodium reabsorption. And sodium, that actually when it follows kind of the urea and the water follows the urea, you actually get an increase in the sodium reabsorption and an increase in the water reabsorption. But there's one more thing I want you guys to think about. You know when you have a low GFR will lead to kind of a low sodium chloride concentration that should trigger your actual macula densa cells to tell the afferent arteriole, particularly the JG cells, to start releasing renin. And then it'll tell renin, hey renin, there's low blood flow, low glomerular filtration, low sodium chloride. I think you actually need to figure out a way to increase the blood pressure so you can increase the perfusion to the kidneys. You should activate the renin-angiotensin aldosterone ADH system. And so you know what happens is this low GFR will actually trigger a stimulation of the renin-angiotensin aldosterone ADH system. And you know what happens whenever you have an increase in aldosterone and an increase in ADH? You reabsorb your sodium in the blood and you reabsorb water within the blood. So not only are sodium and water following urea during reabsorption, but the renin-angiotensin aldosterone ADH axis is being stimulated because of the low GFR and triggering sodium and water to be reabsorbed. And this only works, why? Because the kidney tubules are intact. If the kidney tubules were damaged, this wouldn't matter because you could be releasing these hormones all the way. But if the kidney isn't responding to ADH and aldosterone because those kidney tubules are damaged, it won't matter. But we are reabsorbing lots of sodium and water. And so the sodium and the water will go up in the blood in attempts to be able to increase your blood volume, increase your blood pressure, that you can increase your GFR. What happens though to the sodium and the water within the actual urine? So the sodium concentration, let's actually put like the sodium concentration goes down, and the water actual concentration also will go down. And then if you actually look, we have something called the fractional excretion of sodium, which is basically how much sodium is actually excreted in the urine and compared to how much is filtered. And that is going to be a low amount. We actually say less than 1%. When you actually look at the urine. So the amount of sodium that's actually excreted into the urine in comparison to the amount that's filtered is less than 1%. So these are some of the things that you want to think about. And because there's very little water inside of the urine's very concentrated. And so we say that the urine osmolality will almost be greater than 500. So some of the things that I want you guys to think about for pre-renal AKI is that the kidney tubules are intact. Remember that. So they can reabsorb and they can secrete substances. You have a low GFR because of a low blood perfusion. That leads to more urea, more creatinine accumulating in the blood because you're not actually filtering them. But since the kidney tubules are intact, you can reabsorb more urea and you can excrete creatinine. So because of that, the BUN creatinine ratio will be greater than or equal to 20 to 1. You also, because you're reabsorbing urea can act as kind of like a gradient molecule that can pull sodium and water. So you reabsorb sodium and water. But on top of that, when you have low GFR, it should trigger the activation of the renin-angiotensin aldosterone ADH system. And because the kidney tubules are intact, they respond to that and reabsorb sodium, reabsorb water. So you get more of that in the blood to augment your blood volume and your blood pressure, and therefore your GFR. But less of the sodium, less of the water end up in the urine. So you end up with concentrated urine osmoles greater than 500. Higher this number is, the more concentrated it is, less water there is. Your sodium inside of the urine is actually going to be low because you're reabsorbing it. So the fractional excretion of sodium is less than 1%. The urine sodium is low, usually less than 20. And the amount of urea is also low. Okay? That is pre-renal AKI. Let's now talk about intra-renal AKI. Now, An intra-renal AKI. What kind of happens here? This is an interesting one. So intra-renal AKI, there is some type of kidney tubular injury. These kidney tubules be all jacked up. They're not good at performing their function anymore, which is being able to excrete and reabsorb. Whatever the cause may be that we talked about, they're damaging these tubules. You know what happens when you damage these kidney tubules? The kidney tubules, imagine them kind of like flaking off. Imagine these these cells like flake off. You have a bunch of them, and because they're dying, they start flaking off because you're trying to regenerate new cells to re-epithelialize those kidney tubules. And what happens is whenever they die off, they kind of leave all of these cells that kind of clump up and produce like a really thick kind of like block cast kind of structure. All right, so you get like this thing called here we'll have the urine here, but we'll have this thing, this is called like a cast. A cast is basically like it's a clump of these cells that kind of form to the shape of the tubular lumen. We actually call it like muddy brown cast. But either way, these casts that we have here are actually a result of all of these tubular cells dying off because of whatever the offending agent was, whether it was some type of nephrotoxin or endogenous kind of process, or low blood volume over a long period of time. But either way, there's injury. Now these casts, what do they start doing? If you had something that's supposed to filter across here, and there's supposed to be fluid that moves down. So imagine filtrate should move down, and it should eventually end up through all the kidney tubules and into the urine. Imagine you have a blockage. All of these casts are blocking up a part of the tubule. What does that do to the back pressure? What happens to the back pressure now? Well, now the pressure will start rising. It'll increase the pressure within the tubular system. Now, what do things, whenever you have things that want to move, right? If I had things that wanted to move from the glomerulus into the actual capsular system and then into the tubules, what does it want to move from? Well, filtration, glomerular filtration rate is dependent upon a bunch of different pressures, right? For example, the hydrostatic pressure inside of the vessel, the osmotic pressure in the vessel, the hydrostatic pressure in the capsule, and the osmotic pressure in the capsule. Imagine that the capsular hydrostatic pressure is super high. It's going to now cause things like filtrate that wants to move from the glomerulus into the actual capsule to be affected, because things that want to move where? You always want to move from high pressure to low pressure. That's the desire. But what if the pressure is now not as low as you prefer? It's higher. It's going to decrease the actual glomerular filtration, the amount of substances that will be excreted. So this will be affected significantly, and that will reduce the GFR. Now, if you reduce the GFR, you have less filtration of what kind of substances? Waste products. And so you may accumulate a little bit of urea, and you may accumulate a little bit of creatinine. Right? That makes sense. The kidney tubules, are they working? Can they excrete? Can they reabsorb? Nope. So, guess what happens? The urea that you have here, it was supposed to get reabsorbed. Can it get here to here? No, because these kidney tubules are all jacked up. They can't perform the function of reabsorption anymore. So do you absorb a lot of urea into the blood? No, so there's actually no effect of kind of like that significant urea reabsorption. Okay? That's a big, big deal. Okay, that actually should make sense, right? Now the next question is, can we excrete creatinine? So can these kidney tubule cells take the creatinine that's in the blood, put them into the tubular cell, and then into the urine? No, because the kidney tubules would be all jacked up. So because of that, what happens to the creatinine in the blood? It builds up because we can't excrete it. And so as a result, what happens to the creatinine? The creatinine starts going up because we can't excrete it. Now, if you look at the ratio between the BUN and the creatinine, which one's higher now, if we think about it? Well, the creatinine wasn't actually filtered as much. Urea wasn't filtered as much. But when we talk about reabsorption, not really much urea was reabsorbed, but tons of creatinine was actually retained because you couldn't excrete it. So because of that, look at these arrows. There's way more creatinine in the blood than there is actually urea. So the BUN creatinine ratio will actually be less than or equal to 15:1. Okay? All right, beautiful. So we understand that. Now, what actually will happen then if you can't reabsorb urea? What happens to the urea in the urine? Does it go up? Yeah, because you can't reabsorb it. So you pee it out. You get tons of urea in the urine. Okay, beautiful. Another thing, if you're not reabsorbing urea, can you reabsorb sodium and water via the osmotic gradient? Nope, that's all jacked up. And so now less sodium and less water get reabsorbed, because normally this wants to follow the urea, but it can't because urea is not being reabsorbed. The other thing, when you have low GFR, oh man, we're so good in engineers. When you have a low GFR, what should this do? Should stimulate the renin, angiotensin, aldosterone, ADH system. And you should have the production of aldosterone. You should have the production of ADH. This should want to reabsorb sodium. This should want to reabsorb water. Well, you make these hormones, but are the kidney tubules actually functional that they can respond to the aldosterone and they can respond to the ADH? No, they'd be all jacked up. This process doesn't happen. And so you actually don't reabsorb sodium and you don't reabsorb as much water. So where does the sodium in the water go? Into the urine, my friends. And so you end up with a lot of water in the urine and a lot of sodium in the urine. When you have lots of water in the urine, what do we actually say then about osmolality? What will it be? The urine osmolality will actually be a little bit more dilute in comparison, so less than 350. And the sodium, there's a lot more sodium that's actually being excreted in comparison to the amount that was actually filtered. So what do we say about the fractional excretion of sodium? It's greater than 2%. Okay? So that actually should make sense, all of this stuff. Cool. You know what else? Is this really, intra-renal AKI, really affects not only the excretion of creatinine, but also it affects a lot of the processes of sodium reabsorption, potassium excretion, acid excretion, drug excretion. So this one can really have some significant deleterious effects, leading to a lot of complications that we'll talk about below. All right, so post-renal AKI. Now, the reason why I don't want to go too crazy on the pathophys is that, again, you're not going to really need to know this too much for your exams because it varies, a lot of this pathophys. So, but we'll quickly explain it. So post-renal AKI. Here's the way I want you guys to remember it, okay? Post-renal AKIs, it's kind of like intra-renal AKI, right? Let's actually kind of elongate this tubule here a little bit. So imagine I kind of elongate this tubule, but again, remember, this is after the kidneys, so just remember that. This is after the kidneys. We're thinking about this tubule being a continuation into like the ureter. There's some kind of obstruction, or there's something that's obstructing the flow of filtrate and urine throughout the actual kidney tubules, right? But it's somewhere beyond the kidney. What happens is similar to what happened in the AKI part, intrarenal, is that normally you want fluid to be able to filter across and move down easily without any kind of obstruction or resistance. But if you have something that's causing an obstruction, like a renal tumor, a renal calculus, or a tumor that's compressing down on the ureter, or you have some type of bladder outlet obstruction like severe BPH, this may actually cause the pressure to increase. And so again, if we cause the pressure in the capsule to rise, what would happen to the glomerular filtration rate as a result? It's very simple, right? You obviously want things to move from areas of high pressure to areas of low pressure. But whenever the capsular hydrostatic pressure is high, it's going to lower the actual net filtration pressure and therefore the glomerular filtration rate. And so you have less filtration that's going to be occurring. So we have a low GFR, right? And that's going to be the result of this certain type of obstruction, okay? Now, as a result, we already know that if you have less GFR, you end up with a little bit of an increase in urea, a little bit of an increase in creatinine because you're not filtering off as much of that across the glomerulus. Are the kidney tubules intact? They are. The pressure's built up, but it's not enough to actually cause injury to these kidney tubular cells yet. So the kidney tubular cells are intact. If they're intact, what do? You're able to take any of the urea, reabsorb it. You're able to take any of the creatinine and excrete it. And so you have low creatinine within the actual blood effectively, right? If these are intact, you can do that function. Also, since the urea is getting reabsorbed and the kidney tubules are intact, sodium and water can also be reabsorbed. And because the kidney tubules are intact, guess what else? When you have a low GFR, you stimulate the renin, angiotensin, aldosterone, ADH system, right? And if that has functional kidney tubular cells, aldosterone and ADH, as long as the kidney tubular cells are functional, will increase sodium and will increase water. And guess what? The kidney tubules are functional. And so because of that, if you actually look at the urine, guess what? You'll reabsorb, as long as this is present, you'll reabsorb sodium and water. And so what happens to the amount of sodium and water that's actually present within the urine? It's low. Low sodium, low water. You're able to reabsorb urea, so what happens to the urea concentration? The urea's low. This should look familiar, doesn't it? It looks just like pre-renal AKI. That's what I want you to remember. In the early stages of post-renal AKI, so I want you to remember in the early stages of post-renal AKI, it can resemble pre-renal AKI, where their BUN, creatinine's low, BUN's elevated, right? So they have a elevated BUN to creatinine ratio that's greater than or equal to 20:1. They have a fractional excretion of sodium that's less than 1%. They have a urine osmolality that's greater than 500, and they have a low urea. That's all I want you to remember. Now, what do you think happens in the later stages, guys? In the later stages of someone with a post-renal AKI. Let's kind of elongate that tubule just a little bit. You elongate the tubule a little bit, right? And just imagine that this is some kind of obstruction that's taking place. Again, we're kind of like shorthanding this obstruction. But you have a tubule that's actually blocked there. All right, so we have this obstruction here, right? And again, this is either like a significant renal calculi or some type of tumor, or there's significant BPH, and this has been occurring over a longer period of time. Well, the pressure now is going to increase even more. It was already a little high, enough to reduce the glomerular filtration rate. But now the pressure starts really increasing, that it actually starts exerting some really significant effects on these kidney tubules. And imagine it like this. Imagine the kidney tubules ballooning out, right? So imagine here I had a kidney tubule that was like this, and then after a while, it starts kind of ballooning out like this because of all the pressure. And as it starts ballooning out, guess what kind of is supposed to be running here? Your blood vessels. These poor little guys start getting compressed. And if they start getting compressed, you're going to start reducing the poor little blood flow to these kidney tubules, right? And they're not going to get their oxygen. And they're going to start dying off. If the kidney tubules start dying off, all these poor little guys, and you have all of this high pressure system within the kidney tubules, again, you're still going to have this low glomerular filtration rate because, again, you have high pressures within the capsule. It's lowering the net filtration pressure. So you're still going to have a low GFR. And again, same concept. You'll have an increase in urea. You'll have an increase in creatinine. But the kidney tubules are damaged. If they are damaged and they're not actually working as well because you have so much obstruction that's causing so much pressure to squeeze on the vessels and reduce the oxygen supply and start causing damage, can you actually reabsorb urea? No. Can you excrete creatinine? No. So creatinine starts building up. Urea doesn't actually accumulate as much in the blood. And because of that, guess what? Not as much sodium and water comes over. So less sodium and less water will move over. Also, normally what happens when you have a low GFR? It should stimulate the renin, angiotensin, aldosterone, ADH system. If aldosterone and ADH are present and the kidney tubules work, this should increase sodium. If ADH is present and the kidney tubules work, this should increase water reabsorption. But are the kidney tubules working? No. They're all jacked up. Can you reabsorb sodium and water? No. And so effectively, what happens as a result? What happens then as a result to the actual urine? If we were to kind of look at it like this. You actually look at, here, we'll do it like this so that way we can make some room here. What happens to the amount of urine sodium? The urine sodium will be high. What happens to the amount of water? It'll be high because you're not reabsorbing it via this process and you're not reabsorbing it via this process. What happens to the urea? Well, you can't reabsorb it. So the urea goes up. What happens to the fractional excretion of sodium? It goes up, greater than 2%. What happens to the water leading to the osmolality of the urine? It actually does what? Well, there's actually more water. If there's more water, it's more dilute. So the urine osmolality will be less than 350. My gosh, if this doesn't look like something I've seen before, it's intra-renal AKI. So you know what I want you guys to remember and take away from all of this? I know it was a roundabout way of getting there, but post-renal AKI in the early stages looks just like pre-renal AKI. And the later stages looks just like intra-renal AKI. Because again, what happens to the BUN creatinine ratio in this point? What happens? Really quick. BUN creatinine. Where's the urea? What does it look like here? Well, you don't filtrate as much of it, and you don't reabsorb it. So it's only a little bit elevated. Creatinine, you don't excrete it, and you don't filter it. So it's super elevated. And so the creatinine ratio will be less than or equal to 15:1. This should look exactly like intra-renal AKI. So what I want you to remember for the pathophysiology is we understand pre-renal, we understand intra-renal, we understand all of the diagnostic aspects of it, the clinical applications of it, how this leads to decreased urine output, so on and so forth. But post-renal AKI, in the early stages, it looks like pre-renal. In the late stages, it looks like intra-renal AKI. The last thing that I want to talk about is complications that can happen as a result of someone having a significant acute kidney failure. And when I talk about acute kidney failure, this is really mainly intra-renal AKI that's going to produce these nasty complications. Not as much pre-renal AKI and nowhere near as much as post-renal AKI. So what are some of these complications that I want you guys to think about? Well, you know, whenever the kidney's all jacked up and it's not able to, particularly, again, I want you to really remember intra-renal AKI. The kidney's injured. It's not able to do what to the urea? It's not able to really kind of like reabsorb the urea, but it's also having difficulty being able to filter the urea. And so what happens is you may develop a little bit of a urea buildup. When urea builds up in the blood enough that it actually starts causing azotemia, azothermia is whenever you have elevated levels of blood urea, nitrogen, creatinine. But whenever that azotemia starts actually leading to nasty effects, adverse effects on the body, it's called uremia. So understand, azotemia, uremia, not the same thing. Azotemia is just increased like urea, nitrogenous waste products in the blood. Uremia is the effect of azotemia causing nasty adverse effects. What are some of those adverse effects of uremia? Well, you know, uremia likes to cause platelet dysfunction. What the heck are your platelets involved in? They're involved in clotting, right? So if someone actually has uremic dysfunction, this can lead to, they have elevated uremia, uric acid and creatinine, that's actually causing nasty metabolic effects on the body. It can lead to platelet dysfunction. And platelet dysfunction can lead to bleeding. Ooh, that's not good, right? What else? You know, elevated levels of urea also love to cause inflammation of the pericardial cavity. And so the pericardial cavity that normally is responsible for having just a little bit of fluid in it starts to become super inflamed, and a ton of fluid can start to develop. What do we call that? Well, first off, the inflammation of it is called pericarditis. But whenever it's really inflamed, it tries to increase the secretion of serous fluid. And that serous fluid can lead to what's called a pericardial effusion. Okay? So you can have platelet dysfunction leading to bleeding, pericarditis leading to pericardial effusion, and worst case scenario, cardiac tamponade. And what else? This is really nasty on the neurons. It really affects the neurons and can cause the neurons to become super agitated to the point where they can have excess firing. And this can lead to seizures if it's really high. But it also can lead to what's called encephalopathy, where patients become confused, they become having an altered mental status, they're disoriented. You know what else it actually can do too, besides the encephalopathy, is it can actually cause asterixis. You know, if you take someone's hand and you try to extend it, they start kind of like beating like this. So it can cause something called asterixis. Okay, but these are some of the nasty kind of encephalopathic effects that you may have on the central nervous system as a result of uremia. So one of the big complications is the nasty effects of uremia. What else? You know, the kidneys, they're so good at being able to maintain our acid-base balance. You know, whenever the kidneys are naturally really functional, and we need to be able to maintain our acid-base balance, our kidneys should be able to excrete protons in the urine whenever we're in an acidotic state. But if the kidneys are damaged, you know, protons are actually secreted primarily through an active process by the proximal convoluted tubule, distal convoluted tubule portions. And so what happens is, if your kidney tubules are injured in an acute tubular necrosis, your ability to excrete protons decreases. And because of that, the amount of protons that accumulate within the blood go up. What is this called whenever you have lots of protons that accumulate in the blood? Acidosis. But if it's an acidosis and it's not due to a respiratory issue, it's actually due to the kidneys or some type of other thing besides the lungs being involved, what is this called? A metabolic acidosis. So this can lead to what's called a metabolic acidosis. And what's the nasty effect of metabolic acidosis? It can cause arrhythmias, it can cause hypotension, it can actually cause vasopressors to be non-effective. They're really nasty stuff, man. A lot of electrolyte shifts as well. Okay, so we have metabolic acidosis, and uremia is another potential complication. What else? You know, the kidneys are also good at being able to kind of get rid of excess fluid. So they maintain our fluid balance, not just acid-based balance, but also fluid balance. And so normally, if, for example, our blood pressure was higher, our body would try to say, okay, let's make a lot of urine, right? Or if I needed to get rid of some sodium, I needed to get rid of some water and stuff like that, my kidneys would be able to respond to that. But if the kidneys are injured and they're not able to respond appropriately to hormones, not able to kind of manage the normal water balance because the kidney tubules aren't just working very well, what may happen to the amount of urine that you make? What's the common theme of AKI? Decrease urine output, right? If there's a decrease in the urine output, you're not having as much fluid that's actually being released from the body. And so effectively, you may have more volume in the body. Let's just use that example of water. If you have a lot of water within the body because you're not getting rid of it because the kidneys aren't working well, what happens to the overall fluid volume in the body? You become kind of volume overloaded. And if you lead to volume overload, what can that present as? Well, it can present as edema, right? Maybe in the lungs, pulmonary edema. Maybe within the peripheral tissues leading to peripheral edema, right? So lower extremity edema, maybe some abdominal ascites and associated effects like that, right? So that's one of the big things to think about. So not only can, in an intra-renal AKI particularly, but AKIs in general, complications can lead to uremia, can lead to metabolic acidosis and volume overload. What else? I'm glad you asked. You know, drugs. Drugs are responsible, a lot of drugs are actually renally excreted. So they're excreted primarily in like the proximal convoluted tubule. It's an active process, but if the proximal convoluted tubular cells are jacked up and they're not able to take these drugs and excrete them into the actual urine, what happens? Well, they're not excreted because the kidneys aren't working well to be able to excrete those drugs. And so what happens to the actual drug concentration in the body? It increases. Oh my gosh. What happens if the drug concentration increases? It depends. What if you were taking an anticoagulant? Your kidney's all jacked up. And now you got heparin that's actually accumulating tons and tons within the body. Oh no. Oh no. What happens? You can potentially develop a bleed. You can become hypo kind of coagulable. And so because of that, you can develop bleeds. Or what if you're taking a benzodiazepine for a little bit of anxiety, but you got jacked up kidneys? And because of that, you're not able to excrete a little bit of that benzodiazepine. It accumulates. It causes a significant amount of sedation or respiratory depression. That can happen as well. So you have to be thinking about that. So another thing is it can lead to drug accumulation as well. All right, what else? The last one that I want you guys to think about. You know, the kidneys are good at being able to maintain not only acid-base balance, not only fluid balance, not only a drug excretion, not only removal of nitrogenous waste products, but also electrolyte balance. You know the biggest one that I really want you to think about? Potassium. So normally the kidneys are good at being able to excrete potassium into the urine when it needs to, right? So it's normally responsible for excreting potassium, right? But if the kidneys are injured, especially in an intra-renal AKI, is it going to be able to excrete potassium? No. So what happens to the amount of potassium that accumulates within the blood? It ends up higher. And if you have hyperkalemia, especially really high levels, that has some very deleterious effects on the heart. It can lead to some significant cardiac arrhythmias. Okay? So it can lead to some cardiac damage. It can lead to a lot of different arrhythmias, right? It may lead to bradycardia. It may lead to some type of junctional rhythm. It may lead to particularly, maybe even some type of a heart block. It may even put a patient into like VFib. So that's a big things to be able to think about. So whenever somebody has this significant kind of hyperkalemia, we know, hey man, there's a really bad kidney injury. So what are the complications that I really want you to remember that are associated with someone having a significant AKI? Uremia, metabolic acidosis, volume overload, drug accumulation, and electrolyte abnormalities, particularly hyperkalemia. But if you want to go the extra 9 yards, you can also say hyperphosphatemia. And then sometimes it can even have effects on sodium. Sometimes you may have some sodium retention. Sometimes you may actually get rid of a lot of sodium. And so that could also affect your blood pressure as well. Okay, I hope that part makes sense. Now what I want us to do is finish up talking about the diagnosis of AKIs, differentiating which one it actually is, and then treatment. All right, engineers, so we're at the diagnosis, right? So what we want to do is we want to talk about how do I know if somebody has an AKI? Right? That's the first thing. How do I know it's an AKI? Second thing is, how do I know which type of AKI it is? How do I know if it's pre-renal, intra-renal, post-renal, or if it's like chronic kidney disease and it's maybe an acute on chronic kidney injury? So that's something to think about. Obviously, one of the easiest things is knowing a patient has a history of chronic kidney disease, and then seeing that they have an AKI could be a sign of acute on chronic. But nonetheless, how do I go about diagnosing AKI and then trying to figure out which one it is? Well, first we have to know what is the actual true definition of an AKI, and the best one is the KDIGO guidelines. And so the KDIGO guidelines looks at particularly two things. One is it says, let's take a look at what the creatinine is. So the creatinine is usually elevated, right, in an AKI according to the KDIGO. So we say this is the KDIGO guidelines, or generally the most widely used ones. So whenever the creatinine is elevated, we know that there's an AKI, but like how much? Like at what point do I actually know that this is an AKI? Well, there's kind of a couple definitions, and there's a lot of staging. We're not going to go through all of them. I don't think it's necessary. I want you guys to just remember like 2 points about the creatinine. When the creatinine increases, we say if it's greater than or equal to 0.3 milligrams per DL, usually within like the first 48 hours. So if we see an increase of 0.3 or more milligrams per DL of their creatinine, let's say they came into the hospital 2 days later, it was 1.0 and then now it's 1.3. That could be a sign of an AKI, an early stage, right? Or we say we know what their baseline is, and it's greater than 1.5 times their baseline creatinine. And the higher you go up, the more severe it is. For example, if we say it's 1.5 to 1.9 times the baseline creatinine, it's kind of like a stage 1. And then if you go to like 2 to 3, and then greater than 3, the more you go up, the more times the baseline creatinine go up, the more severe the AKI, okay? And so generally we kind of say 1.5, greater than that at least, you at least have a stage 1. So it goes 1.5 to generally 2, 2 to 3, greater than 3. Okay? So these are kind of two ways that we can look at it in response to creatinine. The other way is urine output. What's their urine output look like? And the easiest way I like to remember that is that they're making less than 0.5 cc's per kilogram of body weight, right? And this is generally per hour. And we say that if it's at least for greater than or equal to 6 hours, the longer you go, obviously the worst case scenario it is. So for example, we say if it's greater than or equal to 6 hours, that's like a stage 1. If you're going up above 12 hours, it might be a stage 2. If you're going up to 24 hours, you're completely anuric, you're not making any urine, then that's going to be getting into the severe stages, third stage of AKI. So these are kind of your basic definition of AKI. So if I had a patient come in, I'm looking at their actual labs, you're more likely to diagnose it off the creatinine. Oh, their creatinine went up by 0.3 in the past 48 hours. Or they have 1.5 or greater times the baseline creatinine within the past 7 days. That's also an AKI. Or if they're in the hospital and you actually have like a Foley catheter and they're monitoring their urine output daily, you're seeing, oh, they've been making very little urine over the past 6 hours, 12 hours, 24 hours, or they're not making any urine. Those can be signs of an AKI. So that's the first thing, is this would be AKI. The next thing we have to say is, okay, what's the cause of the AKI? That's what I really want to get down to. So the first thing that you can do, believe it or not, it's a really quick, easy thing, is we can quickly rule out post-renal. It's usually the easiest one to rule out. And one of the ways that you can do that is you can actually obtain like a renal ultrasound. So you want to go through their history, you want to go through your physical exam, but a renal ultrasound versus like maybe a CT scan of like the abdomen and pelvis would be a way that you can quickly go about doing this, okay? So let's say that I got a renal ultrasound or a CT of the abdomen and pelvis. And when I did, I see that the person had some hydronephrosis. In other words, it looked like their kidney was like ballooning up. And we'll take a look at an image of a hydronephrosis in a second. But if they did have signs of hydronephrosis, there's some plumping up of those good old kidneys. The only reason that it would plump up or get filled with like fluid is that there's something that's causing an obstruction in the ureter or downstream from that. And so that may lead you right into saying, they may have a post-renal AKI. And then you can start looking at their history. Do they have a history of BPH? Do they have a history of prostate cancer? Are they taking any medications like tolterodine, sulfenicin, oxybutynin? Discontinue those. Do they have a neurogenic bladder? Is there a cause for them having this? That they actually, have some type of issue where they have a spinal cord injury, they have Parkinson's disease, they have multiple sclerosis, and that's the reason why they have this neurogenic bladder. Do they have a kidney stone? Okay, I got to fix the kidney stone. Do they have a tumor in their abdomen? You can further evaluate that kind of based off of quickly looking, do they have a renal ultrasound or a CT abdomen pelvis that shows significant hydronephrosis? Other things that you can easily do is check like a bladder scanner. Right? That can maybe show that they have retention. Maybe there's something that's actually distal around the bladder neck or beyond that that's actually causing this. So there's things that help us to realize this. But again, quick, easy one is checking a renal ultrasound, CT abdomen pelvis, and again, other things that you can add on that are commonly utilized is you can consider something like a bladder scan as well. Because this can help you to determine from like the neck down, usually at the level of the bladder, and down if there's something else wrong. Okay, beautiful. Now that we've determined that, we've kind of already said, okay, it's post-renal AKI, and then we can go down the list of all the things ticking them off. It's not this, it's not this, it's not this, or it's this. Okay, we do the renal ultrasound or the CT abdomen pelvis, and we see that there is actually no hydronephrosis. So there's no or negative hydronephrosis. Well, then the next thing we can say is, okay, there's no hydronephrosis. Is this just their chronic kidney disease? Do they have a history of chronic kidney disease? Okay, what if they did? What if they have a history of CKD, and then you also get the ultrasound of the CT of the abdomen and pelvis, and you see that they have very small atrophic kidneys. In that situation, you might say, this may be CKD. And that's it. All right, so sometimes you just have to kind of go through that list. All right, so we have a patient who has some signs of AKI. We got the renal ultrasound. We got hydronephrosis. Maybe it's post-renal. Go through all their particular history and physical exam. Medication list. They don't have hydro. Well, do they have a history of CKD that you can think of? Do they have small atrophic kidneys? It's probably just CKD, and that's why they have this azotemia. Okay. What if they have completely normal looking kidneys? Like on the ultrasound, they have normal looking kidneys. So normal kidneys. Like they look completely normal. There's no abnormalities, no structural abnormalities, no hydronephrosis. They're not small, they're not atrophic. There's nothing like that. They're just normal, good old kidneys. Okay, well in that case, what's the next test that I do? This is not something that we classically do in practice, but it's what you're going to be needing to know for your exam and your boards, is that we may go to doing what's called a urinalysis, so a UA with microscopy. And you might do this with microscopy. Okay? When you do a urinalysis with microscopy, what you're looking for is particular things that may pop up, right? So for example, let's say that you had an abnormal urinalysis. You had an abnormal urinalysis. And let's just say, for example, you got white blood cell casts that show up in the actual UA. You have some bacteria that show up within the UA. You have your leukocyte esterase that are positive. You have nitrites that are positive. What may that be due to? It may be due to a good old infection. Right? Maybe you have some type of pyelonephritis. Sometimes that can cause an acute kidney injury, right? Because we said infections may lead to some type of acute interstitial nephritis maybe, right? All right, or maybe sepsis, Sometimes you can get urosepsis, right? But another thing is, what if we had someone who had white blood cell casts? And this is one we didn't talk about. In acute interstitial nephritis, you get a lot of inflammation. But the particular types of cells that love to migrate to the area of the kidney tubules when there's lots of inflammation, because it's a hypersensitivity reaction? Eosinophils. Eosinophils love to come to that area. And so some of the eosinophils, when they come into the area of the actual kidney tubules and interstitial fluid around the kidney tubules, they get lost into the urine sometimes. So you get white blood cell casts and what's called eosinophils in the urine. We call that eosinophiliuria. Okay? What could that be indicative of? Acute interstitial nephritis. Right? Acute interstitial nephritis, what do you got to think about? Drugs, PPIs, right? Particular types of beta-lactams. Do they have an infection? Is there some type of bacterial, fungal, viral? Do they have sarcoidosis, amyloidosis? Do they have lupus? Things of that nature. Okay? What else? What if I had some red blood cell casts and I had some dysmorphic red blood cells? Right? And let's say that this person also has proteinuria, lipiduria. They got some really weird looking lipid casts and stuff like that. What could that be? What could that be? Glomerulonephritis maybe. So if it is, you're suspecting glomerulonephritis or kind of maybe like a vascularity of some relationship, this isn't where you end. Unfortunately, you may have to go to the level of it's called a renal biopsy. And then when you renal biopsy and do serology tests, that may lead you to say, oh, this is either glomerulonephritis versus some type of vasculitis. Okay? Now, we've gone that way. We say, okay, abnormal UA. It showed potentially pyelo, or it showed acute interstitial nephritis, or it showed glomerulonephritis or vasculitis. What if you had somebody who had these things called muddy, we already talked about these before, but muddy brown cast. This is kind of like one of those buzzword terms you don't want to forget. Muddy brown cast that clogged up the kidney tubules, caused the increased pressure in intra-renal AKI. Acute tubular necrosis, right? We talked about that one. Acute tubular necrosis, this is most specific in. And whenever you have acute tubular necrosis, what kind of AKI is that? Intra-renal AKI. What were all of these that we talked about? Glomerulonephritis versus vasculitis. This was kind of a particular type of intra-renal AKI. AIN is an intra-renal AKI. Pyelonephritis may lead to an intra-renal AKI. And then this also may lead to an intra-renal AKI. So whenever you're going to this point here where you've got normal kidneys, you're at the UA with microscopy, you're trying to differentiate, is this an intra-renal or a pre-renal AKI? Okay, well, we've gotten to that part. What if the UA that we got is completely normal? They got like a normal urinalysis. It's completely normal. All right, if you have a normal UA, the next thing you go to is you check what's called urine electrolytes. Okay? You check their urine electrolytes because this may help to differentiate some of the pre-renal and intra-renal AKI. Big thing to remember, this is not commonly clinically used. Actually, some of the guidelines say not to use the urine electrolyte studies because they're not super effective in differentiating pre-renal and intra-renal AKI. But it's something that you need to know for your exams. So if you check the urine electrolytes, okay, let's take, for example, we have a patient who has a urine sodium that is low. They have a phenol that is less than 1%. They also have a urine osmolality that's greater than 500. And their urea concentration within the urine, their fractional excretion of urea, is also going to be low. What does this make you think of? Pre-renal AKI, right? This should make you think of pre-renal AKI. And then you have to get down to the bottom of it. You say, okay, is this pre-renal AKI that this patient has, is it due to, well, what's going on? Is there some type of volume issue? So in other words, you got to determine, okay, is this some type of issue where they're what's called hypervolemic, right? And this is usually those cases of like CHF, hepatorenal syndrome, nephrotic syndrome, things of that nature. Or is this a case where they're actually like hypovolemic? Their total body volume is low. And those were your burns, your vomiting, your diarrhea, right? It was the diuretic use, blood loss, so on and so forth. Now, in the other part of the test, you have someone that actually has a urine sodium that's opposite. That's actually high, greater than 40 generally. A fractional excretion of sodium that is greater than 2%. A urine osmolality that's less than 350. And a urea excretion that's actually higher. What would this make you think of? An intra-renal AKI. So this would make you think about acute tubular necrosis. All right, so let's talk about the treatment of acute kidney injury. Now, we talked about the diagnosis above. Now, again, keep in mind that when we talk about the diagnosis, this is the way that you would go about in a textbook kind of way. That's not always the way that we actually go through in a clinical scenario. So remember, the urinalysis, urine electrolytes, at that part, it's not always like that in the clinical scenario. And actually the guidelines say that you shouldn't actually stick to utilizing the urinalysis and the urine electrolytes as differentiating the two between intrarenal and pre-renal. And so we'll briefly talk about the actual true best clinical way about going about this evidence-based practice, but also making sure that we're hitting the things that you need to know for your exams. So when I talk about differentiating pre-renal and intrarenal AKI, it's actually kind of how they respond to treatment therapies is really the best way. Looking at their history, looking at their physical exam as well. So let's say that I have a patient who I suspect has a pre-renal AKI, right? And I know that they have an underlying history of heart failure, right? I know that they have an underlying history of heart failure, they have signs of heart failure, they have a particular physical findings of heart failure, and they have a low ejection fraction. If that's the case, then I know that this person would not respond to fluid. That would actually maybe even make them a little bit worse. It would actually cause them to maybe develop a little bit more pulmonary edema. But the problem is that, again, pre-renal, we think about low blood volume, low blood flow. So we constantly say give fluid. In a person like this, it actually might not help. It actually may make worse because it might not augment their blood pressure. In these individuals, you actually want to try to get rid of some of that excess fluid. Pull it into the vasculature, get rid of it out of that third spacing fluid. And so in these patients with cardiorenal syndrome, it's actually best to consider something like diuretics for the hypervolemic state that they're in and all that third spacing of fluids. And the second scenario, you also want to try to augment their blood pressure, not with fluid, but with inotropic agents. Give them drugs that will actually cause their heart to contract a little bit more if they need a little bit of work. So giving them an inotropic agent or a vasopressor of some kind, dobutamine, milrinone, digoxin, maybe even something like norepinephrine or epinephrine, those things may give it a little bit more kick and increase the perfusion to the kidneys, right? So that's one way. We try some diuretics, we try an inotrope, we increase their blood pressure a little bit and we pull off excess fluid and their creatinine improves, their urine output improves. Hey, that was their cause of the AKI, pre-renal. If they have a hepatorenal syndrome, so you know that they have an underlying history of liver failure and hepatic portal hypertension, and we know that they have this issue of low albumin, and we can make sense of this as their potential cause. In that situation, you actually want to trial something called octreotide. And octreotide is basically, it inhibits that splanchnic vessel, it inhibits those vasodilatory chemicals. And so it inhibits the effect of dropping systemic blood pressure, right? And then you can also give another drug that tries to be able to cause systemic vasoconstriction rather than just solely renal artery vasoconstriction. And this is called midodrine. So midodrine will cause systemic artery vasoconstriction. Octreotide will actually inhibit those vasodilator chemicals that are released by the liver. And then what's another problem with the liver? If it's damaged, it doesn't make albumin. So it doesn't keep fluid inside of the vessel. And so in those cases, you can also give them albumin to be able to keep some of that fluid inside of the blood vessel as well. Okay, so that's what we would do for hepatorenal syndrome. Okay, so if you tried some octreotide, some midodrine, some albumin, and it improved, oh, that was the cause. All right, cool. Sepsis. They have sepsis. You maybe see signs of hypotension. They have fever. They have positive blood cultures, urinalysis, whatever it may be. You find a pneumonia, a septic focus somewhere, and you obviously have evidence of sepsis and septic shock. In these patients, you have to treat their underlying cause of sepsis. Maybe that requires antibiotics. And maybe you have to augment their distributive shock, their low blood volumes because they're third spacing fluids, with IV fluids in this case. And maybe you have to give them some vasopressors to be able to increase their blood pressure. So give them fluids to try to keep their effective arterial blood volume up, and give them vasopressors to be able to squeeze on those vessels to increase the pressure, to increase the perfusion to the kidneys, and then antibiotics to treat the underlying cause. For hypovolemia, where they have low volume states, encourage fluid intake. Give them IV fluids if need be, or PO intake. Have them just drink some fluids. And if that's the case, if you have them drinking more fluids and it's increasing their blood volume, increasing their blood pressure, they're perfusing the kidneys, they're making more urine, they're getting rid of that excess urea and creatinine, it improved their renal function. So sometimes one of the easiest ways to determine if it's pre-renal and intra-renal is you can look at their history and say, okay, I think that they would respond to some fluid. I give them fluid, they improve. Oh, maybe it was a pre-renal of a hypovolemic category. Oh, I'm going to give them fluid. They didn't really get any better. It actually made them a little bit worse. Okay, let's try some diuretics and some blood pressure augmentation. Oh, that got them better. Oh, maybe it was a pre-renal AKI of a cardiorenal type, or maybe a hepatorenal syndrome, or maybe a septic kind of patient. So that's kind of the way that we go about this. An intra-renal AKI, it's actually a little bit different. These patients, that's usually because of some type of offending agent, whether it be a drug, whether it be some type of process that we talked about with ATN, AIN, and glomerulonephritis and thrombotic microangiopathies. ATN is the biggest one that I want you to remember. What actually is the best test is giving them what's called furosemide, seeing how they respond to furosemide. If their kidneys are working and they're not damaged, they'll make urine. But if you give them furosemide and they don't make any urine, or they make very little urine, their kidneys aren't working. And it's likely an intra-renal AKI. That's a quick, easy test, right? It's called the furosemide stress test. It was validated in studies. And so what we do is, with ATN, is we have to figure out what the underlying cause is. So what's the biggest one? Those nephrotoxins. Stay away from those sons of guns, right? Stay away from the contrast IF-able. Reduce the concentration of the vancomycin. Discontinue if it's not necessary. Consider another antibiotic instead of aminoglycosides, right? Those are things to think about. The other thing is there anything, what about hemolysis? Treat the underlying cause of the hemolysis. If they have rhabdo, what do you do for rhabdo though? Rhabdo. In early stages, before it really hits the kidneys, you may be able to augment that with IV fluids. They may actually improve with a little bit of IV fluids. For a patient with tumor lysis syndrome, what do you give them? You give them something to tie up that uric acid, rasburicase actually. And then maybe if somebody has like multiple myeloma, you actually have to give them like chemotherapy. So again, it's treating the underlying cause, but remember that ATM is probably one of those that if it's not treated, if it's not reversed, if you don't fix the underlying cause, it actually could potentially progress to a very severe renal failure that requires dialysis actually. Okay, acute interstitial nephritis, it's again, discontinuing the nephrotoxic agents, right? So getting rid of, beta-lactam antibiotics, PPIs, right? Different things like that. It's also considering, is there any underlying infection? Treat the infection. Is there any type of inflammatory process, sarcoidosis, amyloidosis, lupus, something like that? Maybe they may respond to a little dose of steroids, right? Thrombotic microangiopathies and glomerulonephritis, you have to treat the underlying disease. You have to figure out what was the actual cause. Is it HUS? Is it TTP? Is it hypertensive crisis? Is it nephrotic syndrome, nephritic syndrome? All of those things. And that's not something that we're going to go into right now, but sometimes these are kind of like autoimmune diseases, so they might respond to steroids plus or minus what's called DMARDs. So things like methotrexate, mycophenolate, cyclosporin, things like that, right? Okay, last but not least is post-renal AKI, which is going to be the least common. But again, we go through that process. There is a hydronephrosis. Think about their medication history. Think about their medical history. Go through those things and think about it, right? So if a patient has a post-renal AKI and you suspect it and you think, oh, they have BPH, that's probably why. What can I do to help someone who has urine retention from severe BPH? I can give them things called alpha-1 blockers. Terazosin, prazosin, tamsulosin. Those basically work on the sphincter and cause that sphincter to do what? Relax a little bit so that you can get the urine out of the bladder. Sometimes you may even try what's called 5-alpha reductase inhibitors, finasteride, deuteriside. Right? Those help to be able to kind of decrease the stromal development of the actual prostate gland. Take a long time though. But sometimes in the interim, because these do take a decent amount of time to be able to work, you may have to do what's called catheterization. Okay? So you may have to do what's called a catheterization. And this may be something like what's called a Foley catheter or intermittent kind of straight catheterization to be able to relieve that urinary retention. What if they have like a tumor? Well, you got to figure out what the underlying cause of the tumor is and it can be treated. Do they have a kidney stone? Sometimes with stones, you can actually put in a stent. They may pass it on their own. Sometimes if it doesn't work with the stent, maybe you have to do what's called a percutaneous nephrostomy. Sometimes that might actually work. And then again, discontinue the offending medication. What are the most common medications that I want you guys to remember? The anticholinergics, right? Tolterodine, sulfenicin, oxybutynin. Getting rid of those medications that are used to treat incontinence, but actually there's maybe just too much of the dosage, or for whatever reason, it's causing a little bit more retention, unfortunately. Okay, and another thing, make sure that if they have a Foley catheter, make sure that that son of a gun's actually working and it's flushing and it's actually appropriately draining urine. And there's not something that's actually causing obstruction, it's kinked, it's not in the right place. Sometimes that's the simplest thing to actually fix. Okay, you have a patient that you've gone through, you've determined what kind of AKI they have, you've treated it, but they have such significant kind of complications associated with it. And what's the one that most likely will lead to these nasty complications that we talked about? Intra-renal AKI, it's by far the most common. So in intra-renal AKI, what happens is the kidneys become so dysfunctional that they respond in not being able to secrete protons. And this leads to a significant acidosis. Or they have significant inability to be able to excrete particular types of electrolytes. And you know which one is the biggest one? Potassium. And so they have severe hyperkalemia. Or they're actually having high levels of drugs, so intoxication, we'll say. And this is usually due to high drug accumulation, or maybe they took some drug and they weren't able to actually reverse it, or maybe there was no kind of ability for charcoal lavaging, and at this point in time the drug accumulation is so high, you have to put them on dialysis. Or they're so volume overloaded because their kidneys just aren't able to maintain that fluid balance well. Or you have really, really bad uremia, uremic encephalopathy, uremic pericarditis, or platelet dysfunction. Woo, it's all jacked up. Now, in those kinds of situations and the kidneys aren't working, you have to create a kidney for them. And that's where basically, imagine here's our blood vessel. Right? So imagine for a second, this is the superior vena cava and this is the inferior vena cava. And imagine you take a catheter, right? So here's like a catheter. And this catheter, I'm gonna have it pull blood from the inferior vena cava, right? Pulling blood from the inferior vena cava. And then here I'm gonna have one that kind of takes it back to the superior vena cava, okay? Imagine this thing runs through kind of like a colander, right? Here, like imagine this, okay? Imagine there's like a little colander here. And what happens is I'm gonna take and remove blood from the actual IVC. Okay, so blood's gonna be coming from the IVC, and this blood's gonna be nice and dirty. It's gonna have lots of acid, like lots of protons, lots of abnormal electrolytes that are accumulated in excess, potassium, maybe drug accumulation, maybe an excessive amount of fluid that they have that you wanna pull off, or maybe they have lots of urea and creatinine that's building up. You pull that out of their actual venous system and into this kind of like structure here, this colander. And what happens is this colander has an ability to remove. Imagine there's like a little tube here. Imagine there's like a little tube here. And there's like little holes along the length of this. What happens is, as this is actually running through this colander to kind of get back to the venous circulation, which will go this way, it pulls off some of that excess fluid, some of that excess acid, some of the excess electrolytes, some of the drugs, all of those different things, and it gets kind of sucked out of that. And then what happens is this colander is so cool that it also has the ability to put some fluid back in, put some actual solutes back in, some albumin back in, and help to just make sure that the blood is the way it should be, nice and clean. And then it sends it back to the superior vena cava. What's this called? This is called dialysis. And so dialysis is one of the ways that we may have to treat a patient who develops this very severe acute kidney injury. And what are the ways that we can do this? You know, there's two ways. Continuous renal replacement therapy, which is what it sounds like. You're continuously doing dialysis over a long period of time and very slow. Intermittent hemodialysis, you're doing it like every other couple days, okay? For continuous renal replacement therapy, this is for patients who are really kind of like hemodynamically unstable. So for example, you may only pull off 50 cc's of fluid every hour, 100 cc's of fluid every hour. And the patient can tolerate that, because if you pull a lot of fluid off at once, what may you do to their blood pressure? Drop their blood pressure. What if the person's already hypotensive? You pull a little bit too much fluid and you drop their pressure. CRRT, continuous renal replacement therapy, allows for very slow pulling off of fluid, which is very good in patients who are already hypotensive and hemodynamically unstable. For intermittent hemodialysis, you actually take off more larger volumes of fluid, significant fluid shifts. So if that's the case, you would want someone who's a little bit more hemodynamically robust or hemodynamically stable, that they could tolerate pulling off like a liter of fluid in one day, okay? And in a short period of time, like a couple hours. And so if they can tolerate that, you'd go with intermittent hemodialysis. If they're a little bit more shocky, hemodynamically stable, hypotensive, continuous renal replacement therapy may be the way to go. And then eventually, once they become more hemodynamically stable, you may just switch them to doing intermittent hemodialysis every couple days. And then maybe every once a week if they start improving. Okay? So this is the basic conversation that we're going to talk about with acute kidney injury.